Cool. So we are now recording the meeting.
Okay.
Thus begins the afternoon session, at least here in local UK time, of the Hack From Home Expert Speaker stage. I'd like to welcome those of you who've come to join to hear Professor Amy Sheon talking about her work in public health. Among one of the more interesting sets of conversations actually I had whilst preparing this hackathon and the speaker panel for it was with Amy. Had a really great set of insights on the spread of the virus, the data surrounding the spread of the virus. A lot of work building upon many years of expertise in public health. I believe, Amy, you mentioned work on the AIDS epidemic as well, if I'm not mistaken, in the past. So definitely a deep heritage to hear from there. Now, this talk will be recorded, so you guys will have the chance to listen to it later on and hear the benefit of the insights. I think this particular one will be especially useful to a lot of the applications that are being built currently, particularly as regards to the impact of data and location. So Amy's going to speak on public health perspectives on COVID-19 tech development, as you can see on the title here, and then has agreed to speak a bit more on interesting data sets that could be used in the fight later on. And without further ado, I shall cede the floor to you, Amy.
Thank you very much. And I think I'll probably just roll straight from one talk into the next without much break. I'm very, very honored to be joining you all. I run a program at Case Western Reserve University School of Medicine. That's in Cleveland, Ohio, in the cold country. I also work with an organization called the National Digital Inclusion Alliance, and I do consulting on public health innovation. So I'm going to talk just a little bit about the epidemiology of COVID, and then some fundamental public health perspectives that I hope will inform your work, and then do a little bit of a deep dive into one dimension of social determinants of health, as we call them, and an example of public health innovation, and then slide into the second talk on data and data sources. I would imagine people are very familiar with this map. Have people seen it before? Has it been discussed?
Yes, absolutely. Absolutely.
Yes, okay, so I won't spend much time on this. We know, so from an epidemiologic point of view, of course, the epidemic curve is now something that everybody is familiar with. So everybody is now an amateur epidemiologist. But of course, a couple of the fundamentals are the fatality ratio, which is your likelihood of dying if you have it, and then the overall number of deaths for an entire population. And these are, of course, very, very important dimensions, dynamics of the epidemic. And you can also plot them out and look country by country. And I've highlighted for you Italy and China. You can just see country by country the observed the case fatality ratio ranging from 0.5% to 10%, and that goes up generally. The more cases there are, the higher the likelihood of dying. And the bigger the population of a country, generally speaking, you don't have such a strong relationship, but you do have more deaths, of course, higher death rate, usually because there's more density, which makes the epidemic harder to control. Of course, the incubation period is of fundamental importance, and we know that deaths are more common among males, and of course the death rate is very much elevated, higher rates among elderly people, partly because of pre-existing conditions that are more common among older people. Now, one thing that sort of gets lost, I think, in a lot of this is, of course, that the vast majority of cases are mild. But it, of course, is the serious cases that are consuming most of our attention because they require the clinical resources that are of limited supply. Now, right there is where we bump immediately into the distinction between public health and clinical medicine. So I'm going to review a little bit about what is public health so that people kind of understand what they're grappling with. The main thing is that it's talking about the conditions that are required for people to be healthy. And that's really what public health focuses on, using organized efforts at the community level to prevent disease and promote health. Public health activities are done by governments, by private organizations, by nonprofits, and by individuals. At least in the US, the federal government has responsibility for commerce, funding, and national security. The states have the primary responsibility for public health, and states can delegate some of those authorities to the local areas. So that's why you get conflicts about, well, who's calling the shots in terms of, are we under a lockdown or not? Who has access to the strategic reserve that really belongs to the states? That's an issue that kind of blew up in the last couple of days in the US. So there are three core functions of public health. Assessment, which is monitoring the health of the population and diagnosing and investigating cases. And I think it's probably apparent, hopefully some examples of how this applies to COVID-19 are immediately apparent to you. But a big part of public health is around policy development. And of course, now these policies are about things like lockdown and accessing the strategic reserve. Public health strategies are about informing, educating, and empowering people, mobilizing communities, and developing policies. And then the third main function is about assurance, assuring the public, enforcing laws, linking people to care. Public health gives some care directly, but generally it's more about organizing people's access to clinical care, making sure the workforce is competent, and just something here like making sure they have personal protective equipment is, in some ways a public health matter, and then evaluating the success or lack thereof. Now, what I did was then I looked at the different hack from home themes and sort of mapped them out onto these different public health functions and strategies. And I was pleased to see that, and then I sort of went through all of the different ideas and was pleased to see that they really pretty much covered the entire range of public health functions. But hopefully you'll keep those in mind as you're developing your solutions, just kind of understanding where they fit into the big picture. Now I'm going to move through some other really key fundamental public health approaches. The first one is the concept of health disparities and health equity. And I'm going to use a case from the Cuyahoga County, Cleveland, Ohio, which is where I live here in the US, and looking at overall life expectancy, COVID notwithstanding. And what you can see is that we have an enormous disparity between the life expectancy of Blacks, which are 74 years, white 78, and Hispanics 83. This may be different than what you might have predicted, but in fact, it's because of the opiate epidemic that has really hit the white population enough to measurably bring down the death rate. I live in the area that's among the very hardest hit in the country, so it's had a big effect on our life expectancy, but that's the kind of thing we look at. Now, one of the most striking things, though, is when you look geographically, and you've got then huge disparities where the range of life expectancy, depending on where you live, can be 24 years longer. Just going, these are census tracts, so these can be just a few blocks. Your life expectancy can vary by 24 years. I know mapping is such a huge thing in health technology, and to be honest, public health has not really fully appreciated and utilized the value of mapping, especially insofar as data are coming from people's smartphones. So we have enormous reams of data that public health has by and large not been utilizing. Now, when we think about health outcomes, many people are very, very surprised to learn that clinical care actually makes very little difference in the overall health of the population. And I can hear you protesting, but yes, with COVID-19, healthcare is everything, right? Because if you don't have that ventilator, you're gonna die. But if you think back to the tiny fraction, it's just 5% of all the people with infection that have that serious case. You can see that the clinical care will make a difference on the margin to those cases, but really the biggest difference is if we can prevent the huge number of people from getting infections that is going to really drop the number of cases. And so what explains everything else? Well, that's what we call the social determinants of health. And that is health behaviors like tobacco, exercise, diet, the social and economic factors, education, employment, income, support of your family, the safety of your community, and the physical environment, air and water quality, housing, public transit. But when you think about it, these other health determinants affect a huge amount of your access to care and quality of care. So in a sense, it's 20% really overstates the impact of clinical care, because even your ability to get care and the quality of it are determined by all those other social factors. Another fundamental public health perspective is when we think about the type. Is there a question, Irene? No? No? Yes? No?
Nope, nope, sorry, press the wrong button.
Okay. A fundamental perspective is the types of interventions that are done in health and where they operate and the amount of effort that it takes per unit of impact that you're getting. And so when you think about counseling and education, like counseling people to quit smoking, for example, that takes a huge amount of effort, and it has very low effectiveness, right? You have to spend hours and hours of counseling for every person that you can convince to quit smoking. Clinical interventions, treating people for blood pressure, cholesterol, have a bit more effect, but again, they're high effort and low impact. But long-lasting protective interventions like immunizations are much cheaper on a per case basis, and in aggregate, the cost per person is much lower. But the biggest impact you get on health is when you can do things that affect everybody. Fluoridate the water, and the impact, the effort per person is very, very low, and the impact is high on a population basis because everybody is getting the treatment. You don't have to do anything other than put fluoride in the water for everybody to benefit from it. So keep those in mind, because that's really one of the very most fundamental public health perspectives. Another thing is the resources that go to prevention versus treatment. This is an example from the HIV about the effectiveness of doing the pre-exposure prophylaxis, getting healthy people to use drugs that reduce their infectiousness. I'm not going to go through these. I don't expect you can see them, but I just wanted you to know that this is the way that public health people look at it. What is the bang for the buck that I'm going to get in terms of number of cases averted or number of deaths averted from an intervention I might do? Now, continuing on to the disparities and the social determinants of health, you can see that map that we saw of life expectancy looks very, very similar to these other maps of poverty and where people have the percent of people that have less than a high school education. These maps look almost identical, don't they? It starts to get boring after a while. So now when you think about social distancing for COVID-19, now you can see why it's so challenging for people who have the poor social determinants of health. The average 40% of US households have fewer than $400 of emergency savings available, which means that they are up a creek without a paddle if they lose that hourly job. You all know that, I think you know this instinctively, but this is to put a kind of public health lens on it. Not only are these low-income workers hourly, chances are they can't work from home because their work doesn't lend itself, or they may lack a home environment that's conducive to running a Zoom call over their high-speed broadband. They're therefore at much higher exposure to risk. Their houses may be small, unsafe. They may lack exterior space to, get a breath of fresh air while maintaining social distance. Kids are especially vulnerable. They're not going to school where they may be getting free food and where abuse is detected. And the lack of internet puts, just kind of magnifies the risk from all these other social determinants. I'm going to talk a lot more about that later. And this is kind of a case study. Patient portals to electronic health records almost give us a window into what is it going to be like when healthcare goes to telephonic, as it did in the US, like kind of overnight. Healthcare closed its doors. Okay, everyone's supposed to do telehealth now. Well, we know from these patient portals that have been heavily promoted, a big study at our local public hospital, only 30% of patients had ever used them, and the disparities in use are kind of exactly what you might expect. But what wasn't expected was the biggest predictor of whether people use portals was whether they lived in a neighborhood where a lot of people had internet access. And we were, sort of surprised about that. And of course, the majority of these low-income patients were living in neighborhoods where very few people had internet. Well, it turns out that was not just a matter of poor people either don't realize how important internet is or can't afford it. In fact, the main local service provider did not upgrade the capacity from dial-up to fiber broadband in the majority of the area where poor people live. That happens to be the, where Metro Health, the public hospital, is right in there. And people don't have high-speed internet because they couldn't get it at any cost. And so now when we do a map of what % of people have internet, in these darkest areas, only 30% of people have any internet subscription, including they don't have a smartphone with the data plan and they don't have broadband at home. Now, the smoking gun, the hidden social determinant of health, aside from lack of internet, is segregation. And it is true that Cleveland is one of the most segregated cities in the US, but in these darkest areas, more than 95% of residents are Black. And in these light areas, fewer than 5% of residents are Black. So, you've got this enormous disparity. And of course, the same people that, don't have internet also don't have education, don't have jobs, have high lead in their houses and everything else. So I'm going to dig in a little bit to some of these disparities, and I'm showing you here that it's not just Cleveland, Ohio, the entire US. Of course, as you'd expect, elderly are lagging behind in their internet use. Racial disparities aren't as big as you might think, but the hugest disparities remain for people who have less than high school education and people whose income is lower than basically the poverty level. 37% across the entire US of the low-income population has no internet. And in Cleveland, these are magnified. So we have 45% of low-income households, 47,000 total households have no internet whatsoever. So it's really important that you keep that in mind, because I know that, virtually every solution you have, assumes that either people have the internet and they are contributing data to these algorithms, or that people are going to use their smartphones to access services and the like. And Many people think, oh, everybody has a smartphone, so that's solved. But in fact, in the U.S., 25% of people don't have a data plan with their smartphone. If you don't have internet at home and you don't have a data plan, then you're only using your smartphone on public Wi-Fi. And in the era of COVID, people aren't sitting at McDonald's or the library where they can get that free Wi-Fi. Now, I know that these dynamics are very, very different in other countries, but some of this disparity is something that you've just got to pay attention to. So these are just really showing you that all these vulnerabilities are kind of coincide, putting people at just enormous risk. If there are a lot of programs in the US for low-income people to get internet access and data plans, and that can be through the National Digital Inclusion Alliance that was on my first slide. So anyway, wrapping that all up together as you think about how useful, what is the effect of the internet on people's health behaviors, their ability to access care, and their social determinants. COVID just basically is a multiplier of how devastating it is not to have internet, basically. Okay, so I'm going to go through just one very quick example. I don't know if people shake your heads. Well, there's only one head I can see. If you all have looked at this before, the fever map in the US, yes, no, yes, no. So this is a company that distributed 1 million digitally connected thermometers in the US, and they had been using it to monitor irregular influenza. And what they were showing is that the trend is that the influenza epidemic is lessening. And I didn't show you the scale here, but the dark blue is where fever rates that are consistent with regular influenza are lessening. But they detected about 6 weeks ago atypical patterns of fevers that were coming on suddenly and lasting a long time. And they were actually able to detect areas where COVID-19 hotspots 2 weeks before the US Centers for Disease Control picked it up. They actually approached the CDC to say, hey, do you think this might be helpful to you? And the CDC said, thanks, but no thanks. Now, if I were a public health person, I would be paying for every individual in the world to have one of these connected thermometers and have them sign away their data, so that anonymized, de-identified data were available. Now, I just went back to look at this yesterday to prepare these slides, and they've added a new dimension, and they're showing you how the onset of social distancing rules translate to a reduction in atypical fevers. So in this one community, they show you on March 13th, they said no gatherings over 250 people. And you can see that the fever rates had been pretty constant, but immediately started dropping. They then closed bars and restaurants and closed schools, closed daycare, non-essential businesses, and you can see that really reinforces immediately how valuable it is to flatten the curve. You don't have to do, this is classic public health, you don't have to do testing. You're just getting data that are being collected incidentally. This is New York City, where the epidemic absolutely is now starting to drop because of the stay-at-home order and the closing of restaurants and bars. Now, this juxtaposes two different communities, the infamous Miami, Florida, where they didn't want to close things down because they didn't want to lose the money from all those spring breakers who were coming down there. And you can see that even though they declared a state of state of emergency, they didn't close the schools until here. bars here. The epidemic still didn't turn around, you know, for a little bit, because all those people had still gotten exposed. But then the epidemic, you know, started to wane, probably because people started responding on their own despite orders, because of what was clear from other places. So anyway, I just think this is a beautiful example of how health technology can, it's almost usurping what public health does. And unfortunately, public health hasn't really realized it, which is why I started a company called Public Health Innovation. Okay, and now I'm going to move, I'll pause for any questions as I move into the second talk.
Thank you, thank you. That was a really, really interesting talk. And I think, you know, your point upon COVID-19 as a hugely aiding inequalities ahead is a very important one. There was an article I noticed in The Guardian a couple of days ago that said singing stops in Italy. Music and singing stops in Italy as the tensions of epidemic bite. And this just shows, you know, so many people who are already slightly unstable or on the breadline or close to it are hit so heavily by this. I was very struck with your infrastructural point around people's access to the internet. I'll confess I had no idea that it was that high in the United States, and then even higher in those particular regions. That was quite surprising. It does make me wonder how in other countries, where there might already be low internet connectivity, and where, for instance, there might just be simple lack of access to running water and soap, as well as incredibly dense populated areas in certain areas, how they're going to deal with this issue. The prospect isn't a good one.
Well, you know, thank you for those comments. They're spot on. Interestingly, in you know, many parts of the developing world, they jumped on the wireless technology very, very early on, because getting, you know, wired landlines was so difficult. And as a result, public health in developing countries has been extraordinary, where, you know, they're equipping community health workers with mobile tablets to do data collection and interventions using satellites, satellite internet and all. So I think, you know, sadly, COVID-19 should be an epidemiologist's, you know, dream come true, with the kind of data and things we're going to be able to learn because of, you know, the information we have from connectivity. And the U.S. Has not regulated broadband. Its connectivity is more expensive. Data are more expensive in the U.S.
Yes.
than most of Europe, and slower. And I think we have ceded our space in world leadership and set that in stone by our internet policies, unfortunately. If there is any silver lining of the COVID-19 epidemic, it's that there's immediately been recognition that, oh my gosh, 6 million households have kids that can't do school online. And healthcare hasn't quite realized who isn't going to be jumping on telehealth, but hopefully they will pretty soon.
So
okay, yeah.
Sorry, I mean, there's a whole range of questions. I'd really love to dig you in on this, but there's obviously we are at a hackathon. I want to ask if there was one central insight that you could offer based upon the slides that you've presented and your research in general, to what kind of, you know, applications could be useful in this time as you see it. Like what applications should be striving to do in how they construct themselves? What would it be?
Well, I think the most important thing is to be very, very conscious of disparities in access and use of the internet. And I would say probably half of your applications are ones that are powered by data that are being generated by, by internet connected devices. And so you have to be thinking of who is not contributing data to that universe, right? So older, at least in the US, older and poor people are underrepresented. Rural people are underrepresented, but what's not widely recognized is that the vast majority of people in the US who don't have internet are living in urban areas. And it's because of these structural racism, bias policies and processes that allowed internet service providers not to serve everybody.
Digital redlining, I suppose.
Yes. In fact, the term digital redlining was invented after that work in Cleveland that showed, that AT&T had not serviced the poor area.
Fascinating, fascinating. Now, we've had a question come in, two questions, in fact. So the first is from John, which is, and I guess this is perhaps is this perhaps an American question, John? I'm unsure, but it says, is it possible that the new internet requirement for distance learning for the underserved will help provide access to healthcare also?
Funny you should say that. Yes, insofar as schools have taken responsibility for getting their customers, which is students, connected. So massive, albeit disorganized and inefficient mechanisms have been set up to get devices to people. And a lot of the internet service providers are offering 2 months of free data. Well, I think they're doing that because they know that the alternative is that the government is going to, come in with regulations where they haven't regulated before and require, them to make internet available to everyone. So those families will be able to use telehealth. Employers who've sent employees home, they are also taking care of their employees to get them connected. Healthcare has not turned around and said, well, gee, if we're now closing our doors and only offering telehealth, maybe we should take responsibility for getting our customers connected. That is not happening. I am doing my damnedest to shame them into doing it, but that needs to happen, but hasn't. Interesting.
We've had another question from Peter Whitehouse, who says, he works with intergenerational schools. What could be creative ways to keep kids and elders connected?
Oh, Peter, what a great question.
Using tech, I think, was the additional factor there.
Right. I've heard that there are models run by a fellow named Peter Whitehouse that brings kids and seniors together in school programs. Kids who are, digital natives have a great opportunity to, kind of partner with seniors to help them get connected. Seniors can be very motivated to get connected, to see those grandchildren on Facebook. However, what we know from our digital inclusion experts, those are people working in libraries and the like, who's are skilled at digital skill training, know that you need to have a certain mindset and patience to help people use technology. There's an expertise, there's a methodology, and some people just have a disposition that's more suited to that than others. It helps to learn the cognitive processes that people go through in learning digital technology. You have to get over your fear, for example. So if you can teach kids how to teach older people to use computers, you can get an even bigger bang for the buck.
Interesting, interesting.
All right, shall I jump in to talk to?
Yes, I had, there's one more question.
Yeah, go ahead.
So just picking up on the concept of the digital redlining, which is, can remote healthcare services being researched over 5G internet actually be effective for general people in general, I guess? This is from Ashraf.
Absolutely. But what I think is fundamentally important is that people have that video connected telehealth. Otherwise, they're doing what I'm calling telehealth, which is an audio only connection. The video connection provides the healthcare provider with so much more information. They see the person's affect. They see their ability to move. They
Mm.
see the home environment. They can, look at, something physical, a physical sign on the body. They can ask the patient to show them their medication bottles and make sure they're taking them correctly and not, overdosing, and, do many, many parts of the standard clinical care that you cannot do with an audio only. So telehealth is second-class healthcare. We cannot and should not accept that for people who don't have video. We must get them all on video connections.
Awesome. Well, thank you for that, Amy. Now, I've had two more things come in.
Yeah.
The first is a piece of information on something called the Sovereign Digital Guardian Group, which is looking into issues of social inclusion. That's from someone called SHP, who I think was one to flag that to your attention. It's basically giving, as I understand it, a guardian to people to help look after them in that regard. So it would be worth you checking out, perhaps, if interested. The other one is from Mindy, who asks if there's any research on how technology, including apps, gamification, visual and verbal cues, can be used to apply to healthcare education, can be used to reduce costs and improve effectiveness. And then that, ladies and gentlemen, will be the last question before we go.
Well, funny you should mention that. Over the last year and a half, my team has built a virtual reality application that was meant to take all those data I showed you. The mapping data is something I do through my work with a platform we've created called Health Data Matters. We wanted to be able to create a visceral experience for people of what is it like to live in, this kind of environment and try to look after your health and get health care. And lo and behold, the Ohio Department of Medicaid, which is the healthcare insurance for poor people, came out with a request for proposals for virtual reality simulations to increase the knowledge of providers around social determinants of health and increase their empathy to improve the care that they give to poor people. And so in February, we started putting these virtual reality goggles on as many healthcare providers' faces as we could and as quickly as we could. And then COVID-19 came out, and suddenly it didn't seem like such a good idea to put a mask on one person's face and then move it as quickly as you could to someone else. So we're translating that to a web-based platform. But I think increasing provider awareness about these dynamics is really, really key. It doesn't do any good for a provider to, tell a patient to, just go online and X, if the patient in fact isn't online. Providers should screen every patient for their digital skills and connectivity. I've built a screening tool for that. And anyway, those are all those gaps of public health meets technology or fails to do so, trying to bring technology into public health.
Interesting. And I guess that comes back into that pyramid of interventions you talked about earlier in a sense as well.
Yeah.
Well, look, that's been a fascinating talk. As I said earlier, I could keep on going on this talk alone for quite some time, but how about we turn now to the second of your two exciting sections, which is the data sets.
And are you seeing my screen, the full screen?
Yes, agenda, review of data sources.
Okay, so
yes. One second, I've been asked to reset the recording, so I'm just going to stop the recording.